Good morning, everyone. Thanks so much for taking the time out of your busy day to join me today. We are going to discuss the topic of VAE. This is the second in the series that started last week. If you all have not received the slides and the webinar link for the recording last week, let myself or Lexi know and we'll be happy to send that to you. Just a few housekeeping tools to talk about. If you're not familiar with, excuse me, with Zoom, when you click on your control box in the right-hand side, you'll see three little dots, and if you click on that, it says More, and if you'll click the chat box, that will bring up your chat box. So if you have any questions or you want to communicate with other attendees of the webinar, you can do it through that modality. If you are listening in from your phone line and have your computer speakers on, please mute your computer speakers because it will ring as an echo and it'll give you much better listening quality. Don't place your calls on hold because then I'll be able to hear your music from your facility. And then we're going to use the chat box for all discussion today. So if you could answer questions and input questions through the chat box, that will be great. This session is being recorded and will be sent out in a couple of days after Lexi has a chance to listen to it and make sure that it sounds good. So just to give you all a little chance to practice with the chat box, I'd like to know who is in the room today and what facility you're with. So if you could just take a minute or two and put that information into the chat box, I would appreciate that. Welcome, Lexi. Hi, Michelle. Welcome, Nancy. Glad to have you aboard. Hi, Deborah. Okay, next question. Just to get to know you a little bit better, are you partial more to apples, pumpkins, or both? And if you have a great recipe, I'd love to hear about it. Okay, I've got some apples and I've got both. I would have to agree with you, Michelle. Mine is both too. Okay, we will go ahead and get started here. So, as I said, this is the second in the focus area of Ventilator Associated Events. Last week, we kind of talked about a tool that we could use or that could be used to ensure that ventilator compliance is being adhered to. I'd be interested to hear from all the participants today whether they have an algorithm or a tool that they use, if they're doing it just through chart review, or if they're actually doing a daily round or inspection of everybody that's on a ventilator. I didn't get many assessments back when we initially set up the webinar series. So today I'm going to take a little bit of time and go through some of the criteria that are under NHSN and how it will, whether events will qualify for reporting to NHSN or whether they won't qualify. And I'll be the first to admit I am not as familiar with the VAE reporting through NHSN, but I would love to hear any stories, pain points, concerns those of you that do report into NHSN have been having. So, moving forward, the intent of the objectives within the VAE webinar series is to increase the awareness of identifying and reporting all ventilator-associated events, utilize root cause analysis tools to assess VAE practices. And I'll tell you, NHSN has a great tool out there built. You can use the VAE calculator, but I'd also be interested in hearing from facilities on whether they have homegrown algorithms or checklists that they use that have been successful to them as well. We're going to talk a little bit about defining and utilizing best practices for process improvements. And then, as always, with the intent of our webinars, it is to jumpstart your current activities and or build upon those. I want to stimulate action and stimulate conversation between facilities. You know, healthcare is hard enough if we have to do it on our own, and we've all got great practices that we do and share on a daily basis. And I'd just like to bring those to the forefront with everybody that's in attendance today. So, according to NHSN, a VAE is defined as a patient who has had a period of stability or decreasing PEEP, which is the positive and expiratory pressure, or FiO2 values, greater than or equal to 2 days. The patient must have been mechanically ventilated at least 4 days, where the day of intubation and initiation of mechanical ventilation is day 1. The earliest day of the event for mechanical ventilation is day 3. So in order to have a ventilator-associated event, the patient has to be experiencing increased PEEP values over the daily minimum for the preceding 2 calendar days. So in other words, you have a patient who, say, has been intubated for 4 days, and day 1, you're noticing that they're stable. Day 2, you're noticing that you can start to decrease their PEEP and or their FiO2. You're thinking about potentially starting to wean that patient. But then on day 3, you notice that they're not doing as well, that they may have a little more congestion, or there may be, you know, just some increase in work of breathing. And so you're not able to extubate on day 3. And then day 4, you notice that their PEEP is starting to creep up, or that their FiO2 is starting to creep up. And so clearly you're not going to be able to extubate. At that point, day 3 would be an indicator to say, hey, we might be dealing with a VAE. Likewise, for PEEP values increasing and going over 3 centimeters per day, or the FiO2 increasing 0.20, those are the indicators for VAE. For the facilities that are on the call, do you find that the NHSN tool does a good job of clarifying and breaking that out for you, or do you have difficulty attributing those types of events in NHSN? I'll give a minute or two for folks to answer. Okay, Deborah, I see that you don't use NHSN in your role. Do you have a tool that you use to recognize when patients are starting to have issues with ventilators? Okay, okay. Nancy, I see that you commented that the NHS tool is very helpful. I would agree. When I was preparing for the webinar and went through and looked back through the device-associated module for VAE under NHSN, their algorithm does a great job of explaining that. Out of curiosity, with your policies and or your procedures surrounding VAEs, have either of you or has any facility incorporated the criteria from NHSN? Okay, Nancy, you've indicated not specifically. Just out of curiosity, has your facility identified anything through order sets, or does RT have criteria that they use when looking at somebody with a potential VAE? And if not, you know, it might be something to potentially consider if you're starting to see VAE events occur in your facility, you know, possibly pulling this out, the algorithm out from NHSN and sharing it with RT, sharing it with, you know, the medical director for ICU, CCU, trauma, just to see what their thoughts are and whether it can be incorporated into your order sets and or policies, procedures. The next topic we're going to talk about is ventilator-associated condition. Now, back in 2013, CDC did do some tiering with the VAP definition, because they found after hearing from facilities that VAP was such a broad definition and it was very hard to interpret. So what they did was they broke it down a little bit further. So when you go into NHSN, you will have VAE, but then you will also have the VAC, which is the ventilator-associated condition. You will then have infection-related ventilator-associated complication, which is IVAC, and then the last criteria or selection will be possible ventilator-associated pneumonia. And so I just want to take a little bit of time and go through this just a little bit. So a ventilator-associated condition, according to NHSN criteria, is on or after day 3 of mechanical ventilation and within 2 calendar days before or after the onset of worsening oxygenation, sorry about that, the patient meets both of the following criteria. So in other words, in order to qualify for a VAC, the patient has to have a temperature greater than 38 degrees Celsius or less than 36 degrees Celsius, or a white blood count greater than or equal to 12,000 cells, or less than or equal to 4,000 cells. And so it can be a little confusing for anybody who's in NHSN, because it tells you that they have to have both of these criteria in order to meet a VAC, but then they can have either a temperature or a white blood count. They don't have to have both of those. And then it goes on to say that a new antibiotic is started and continued for greater than 4 qualifying antimicrobial days. And so the patient has to be started on a new antibiotic as well, and it has to continue for at least 4 days. I find that the calculator in NHSN really does a good job of helping break that down for you when you're inputting that information and abstracting your data. A lot of times what I hear from facilities is that they're pretty sure that a patient may qualify for a VAE or perhaps may qualify for a CAUTI or a CLABSI or something. But then when they go in to complete the algorithm and or the calculator, they find that it doesn't meet all of the criteria, and so they don't consider that as a event in NHSN, but they consider that as an event in their facility. Nancy or Deborah, do you guys, how do you work that in your facility? If you put it into NHSN and it doesn't meet all of the criteria, do you then count it as an event for your facility, or do you just leave it as is and not qualify it as an event? I'll give you a minute or two to answer. So Nancy, you're saying that you only count it as an event when the calculator says it is a VAC, a VAE, or an IVAP. Okay, Deborah, that makes sense. I would have to agree with you, Nancy. I would be under the impression that if it doesn't meet all of the criteria under the NHSN module or the calculator, I wouldn't qualify it as one either. They have very clear descriptions as to what qualifies and what doesn't qualify. I just find it interesting that some facilities would qualify it as a potential event for their facility when it doesn't meet the criteria. So thanks for your input. Moving on and talking about infection-related ventilator-associated complication, or an IVAC. So if you haven't been into NHSN and looked at the algorithm, this one is a little more complicated than the ventilator-associated condition, but it goes through and it spells out what would potentially qualify. And there are 3 different criterions within the IVAC. So generally, a patient on or after day 3 of mechanical ventilation and within 2 calendar days before or after the onset of worsening oxygenation, one of the following criteria has to be met. And so this is where the 3 different criteria come into play. So the first criteria talks about a positive culture on one of the following specimens as meeting quantitative or semi-quantitative thresholds as outlined in the protocol. And by the protocol, it's talking about what's below, without the requirement of purulent respiratory secretions. So the patient doesn't have to have purulent secretions for this. So you would have a positive culture from an endotracheal aspirate to over 100,000 colony-forming units per ml, or corresponding to semi-quantitative culture. Bronchial alveolar lavage 10,000 colony forming units per ml or corresponding semi-quantitative result. Lung tissue, from those bronchoscopies potentially, or a lung biopsy, 10,000 colony forming units per gram, or protected specimen brushings. Colony forming units, or corresponding semi-quantitative results. Next criterion is purulent respiratory secretions, defined as secretions from the lungs, the bronchi, or trachea that contain greater than or equal to 25 neutrophils and less than or equal to 10 squamous epithelial cells per low power field, plus the organism identified from one of the following specimens has to have a qualitative or quantitative, semi-quantitative culture without sufficient growth to meet criterion number 1. So this is where, when it comes to an IVAC, you really do have to have as much diagnostic criteria available to you in order to make that determination. So cultures, potentially histopathology results, all of those will help you determine whether it's 1, 2, or 3 within the IVAC event. Secretions can come from the sputum, endotracheal aspirate, bronchoalveolar lavage, lung tissue, or protected specimen brushings. And then there's just a little note that says, for additional instruction on using the purulent respiratory secretions criterion, just to go into the device-associated module with VAE under NHSN. The last criterion to potentially qualify somebody for an IVAC includes the following positive tests: either an organism identified from pleural fluid obtained during thoracentesis or initial placement of chest tube, and not from an indwelling chest tube. So it can't be from a chest tube that has been in place for 2 to 3 days. It has to be the initial placement of that chest tube. Lung histopathology, which is defined as an abscess formation or consolidation with intense neutrophil accumulation in bronchioles and alveoli. Evidence of lung parenchyma, invasion of fungi, evidence of infection with viral pathogens, which are listed below. And what that is it's talking about pathogens based on results of immunohistological assays, cytology, or microscopy. So, and then it goes on to identify that if there's a diagnostic test that comes back positive for Legionella, or diagnostic test on respiratory secretions for influenza, respiratory syncytial virus, adenovirus, parainfluenza virus, rhinovirus, human metapneumovirus, and coronavirus. So that's where that respiratory assay comes into play as well. Just out of curiosity, for you folks that are reporting to NHSN with these types of events, do you share this with your medical staff, whether they meet or don't meet criteria, or trends on potentially what you're seeing? How do you share potential event information with your staff? Good point, Lana. Lana says that she finds that with facilities that they share this during multidisciplinary rounding. I like that idea because I like the fact that you are getting input from various disciplines, you know, and potentially having extra eyes and ears and sharing perhaps what a provider may not see or that or a nurse may not see. So I like that. Nancy, you said that you are sharing VAE findings at quarterly infection prevention meetings and with the manager as it occurs. I like to hear that as well. Do you find that your manager and the staff in those particular units are appreciative of that? I always found that when I was a frontline nurse, that when I was working bedside, that I like to hear about things that were potentially going on, and then review that with my practice to make sure that I was adhering to policy procedure to prevent injury to patients. So I'm glad to hear that. Nancy goes on to say that they do a deep dive on VAEs with managers as well. Do you find that your managers are appreciative of that, Nancy? I mean, it gives them, to me, it would give them an opportunity to continuously look at policy practice to ensure that they're adhering to that evidence-based information that's out there. Good to hear. Nancy says that they also share the information with bedside nurses. I'm glad to hear that. Moving on, we'll talk a little bit about possible ventilator-associated pneumonia. In this one, from talking to my facilities that do utilize ventilators regularly, this one is kind of a problem child for them, if you will. Because in order to qualify it as a possible pneumonia, the patient has to meet the VAC and the IVAC definitions under NHSN. And they also have to have positive results of new antimicrobial testing, which would include positive culture meeting specific quantitative or semi-quantitative thresholds, purulent respiratory secretions, and identification of organisms not meeting the quantitative or semi-quantitative thresholds. Organisms can come from pleural fluid, positive lung histopathology, lower respiratory specimen cytology findings suggestive of infection, or positive diagnostic test for Legionella species or selected respiratory viruses. And that would go into all of those viruses that we talked about under the IVAC. So the influenza virus, RSV, the human metapneumovirus, all of those things that might possibly show up on that film array for respiratory viruses. Moving forward, we'll talk a little bit about knowledge nuggets, if you will. These were just some things that I gleaned when I was doing my research, you know, in peer-reviewed articles, but then also what NHSN has. So if a patient meets criteria for a VAC, which is a ventilator-associated condition, or an IVAC, then you report it up as an IVAC through NHSN. If a patient meets criteria for VAC, IVAC, and PVAP, you report it up as a PVAP. NHSN cautions us to not upgrade an event using findings that occur outside that VAE window. And so when you're talking about that VAE window, you have to understand that the patient has to have been ventilated for a minimum of 4 days. And they have to have had at least a 2-day stability period before you can start considering whether a VAC, IVAC, or PVAP event is brewing. It's important to keep those pieces in mind when you're thinking about whether this would qualify or not qualify. You would not report pathogens for a VAC or an IVAC. So within the criteria that NHSN has available to facilities, you would not include the pathogen of that. You also don't consider secondary bloodstream infections when it comes to VAC or IVAC events. Those are not contributable to the criteria to meet NHSN. Pathogens that are reported for PVAP events, provided they are isolated or identified from the appropriate specimen types according to the requirements of the algorithm, and are not included on the list of excluded organisms. So within the tools that I've put out here for folks to utilize, I've included the VAE calculator for facilities, and then also included the potential paper form. I was always the type of person that when I was out reviewing charts, I didn't necessarily have access to a computer. So I did print the algorithm, and I did print the collection tool, because when I was going through charts, then I could actually see and read what it was that would potentially qualify. So, you know, and one of the other things that you can do is potentially laminate pieces and make it as a badge buddy. I've seen that at a facility that I was at where when they're looking at potential ventilator associated events, they've made badge buddies, or they've laminated it and put it out there, you know, on their communication board for staff to review and look at. So I'd be curious to know if facilities have anything like that. Have you utilized badge buddies, or have you laminated this? I'd also be interested to know if you do any type of competency or education with the staff in the ICU and CCU when it comes to ventilator-associated events. Feel free to put anything out there in the chat box that you feel other facilities could utilize. One of the things that that we talked about last week that I would like to just reiterate is that, you know, it's not, oh, Nancy, great. You said you created a VAE competency for ICU nurses and RT. Can you speak to that a little bit? Do you have a ventilator there for staff to play with? Tell me a little bit about that competency. I agree, Lana. Nancy, Could you send that to either myself or to Michelle in order to share with facilities? I think it would be great to see what you've done and put it out there as a resource for potentially other facilities to use. Okay. So moving forward, as I said, these are the tools that I developed, or not developed, that I pulled together for facilities to use. It has the VAE calculator. And as I said, and Nancy, you alluded to, you know, that it being very easy to use. I would agree with you again that the calculator is pretty easy to use, and it helps define a cut and dry, if you will, of whether you're dealing with a potential event or not. As I said, when I was out doing rounds, I would take the collection tools with me because it gave me, you know, that criteria that I could follow up on and review. And then just another visual cue. We talked about this last week, but when it comes to the bundle, you know, one of the resources that I ran across had developed what's called a heads-up visual cue. And essentially what it was is they used the mnemonic heads up, and it's to look at the head of the bed, enteral feeding or oral care. A is for air mattress and pressure strategies, looking at DVT, PE prophylaxis, ulcer prophylaxis, and pain control. And so I thought that was a very easy tool to utilize and, you know, have available to staff, you know, potentially in those rooms where you've got patients who are on ventilators, having a little poster such as this. Nancy, do you guys have any type of mnemonic or visual cues, displays in your ICU rooms? That speak to the bundle? Nancy says that they use a vent bundle email daily to the doctor and manager of items that are missing. I think that's a great way to share information. The fact that you're doing it on a daily basis is a great idea too. I know, at least with my experience, has been if it's out of sight, it's out of mind. In ICU nurses, CCU nurses, trauma nurses have enough going on without constantly having to remind themselves, oh, I need to check on this, I need to check on that. So anything we have online or available to them ensures that standard of care, if you will. So again, I just want to talk a little bit about, you know, getting started. If you're not doing anything with VAEs, or if you don't have a tool available or wanting to change it up, you know, the first thing to look at is what does your data show, or where can we have the greatest impact? Because patients that are in those types of settings are so complex and require so much time, you want to make sure that it's something that is easy to get started on. You want to grasp that low-hanging fruit, if you will, and capture those pieces. That way it starts a positive trend and really does help engage staff, leadership, providers, and identify the good work that's going on. You know, utilizing the Plan, Do, Study Act is a great way to get started. And again, you know, Nancy's willing to share her pieces with us. Don't reinvent the wheel. If you have a facility that you work with closely or that you share ideas with, you know, reach out, share, grab those little nuggets, if you will. The HIIN also has a great deal of resources when it comes to Ventilator Associated Events. We just want to make sure that everybody understands what is involved in the metric, and honestly how detrimental it can potentially be for not just patients but also facilities when these types of things occur. Nancy, I'm going to put you on the spot here. If you had to identify one particular thing within the ventilator bundle that was problematic for you when you first started, you know, given that you've done the competency and whatnot, what would you say it was and how did you overcome that? Nancy says the hardest item to overcome is to get the doctors to write the correct orders for the needed items in the vent bundles. I heard that a couple weeks ago when I was out on a site visit as well. As much as computer order entry for physicians has, I hope, eased their burden, sometimes it's not as easy to do the right thing, if you will. So just out of curiosity, when the orders are put in and it's identified that they're not correct, do the nurses contact the providers? Do the managers contact the providers? How are those handled? So Nancy says that they made an order set for each pulmonary doctor. Good idea. Trying to standardize and yet individualize per provider a lot of times is very helpful and prevents those calls and, if you will, the beating up of the providers. So good way to handle that, Nancy. Thanks for sharing. So we're coming to a close. I just want to share, again, resources that I utilized for development of this VAE webinar series. Definitely CDC, the IHI has a lot of great resources, as well as AHRQ has a lot of great resources. I look for this to continue to be, you know, at the forefront of care for patients, especially in ICUs and CCUs, because ventilators, you know, are an integral part of providing care to those patients. But as healthcare continues to mature, if you will, I think we're going to find more and more people are being moved to alternate forms of respiratory assistance rather than using ventilators. What I started reading was that they're starting to use more CPAP, more BiPAP, and try and keep patients off of ventilators because it can be very difficult to get them weaned off. So I think this metric in and of itself will probably be changing a little bit more in the coming years. Nancy, would you say that your facility is starting to utilize other forms of respiratory support as opposed to using ventilators and only using ventilators as a last resort? Nancy says, yes, CPAP and BiPAP. Yeah. Just out of curiosity, with those two policies, is nursing allowed to adjust the settings on those, or is it just respiratory therapy? Just the doctor and the respiratory therapist. That's what I see in a lot of facilities as well, is that it's just the provider and or respiratory therapy. I, as a bedside nurse, would not have felt comfortable adjusting or manipulating CPAP or BiPAP, let alone a ventilator. So thanks for sharing. That's all I have for this webinar. I have the other clinical quality consultants on the line. Do you ladies have anything that you'd like to share? Ashley or Michelle or Lana? Okay. Next week, we will start our C. diff topic. It used to be Clostridium, and now it's Clostridioides. Oh, that's a mouthful. Difficile. We're going to talk about what it is and what it isn't, surveillance versus containment, the importance of your data, and who's on your prevention team. For those of you that have been on the VAE, I would encourage you to have your infection prevention folks, EVS for this series, frontline staff. I would love to hear input from facilities who are struggling potentially with C. diff. And if you're not, you know, what are your good practices? What do you want to share? So just to let you know, that will happen, as I said, next Wednesday at 11 o'clock. And so I look forward to people attending. So the content from today's webinar can be shared with your team. A link to access the recorded webinar will be sent along with the slides from today's webinar. And then if you haven't registered for next week's webinar, I encourage you to do so. I will give you back about 10 minutes of your day, and thanks so much for joining. Have a wonderful afternoon.